Welcome to Clinical Tools Library, evidence-based scales and questionnaires designed to support healthcare professionals in practice. The trail-making test assesses cognitive functions, including visual attention, processing speed, and task-switching ability. It primarily evaluates executive function and cognitive flexibility. The test is widely used to detect impairments in patients with neurological conditions such as stroke, traumatic brain injury, and dementia. Performance on the test reflects the integrity of the frontal lobe and related neural circuits. The main purpose of the trail-making test is to provide an objective measure of cognitive deficits for diagnosis, treatment planning, and monitoring disease progression. The trail-making test is indicated primarily for adult and elderly patients experiencing cognitive impairment or suspected executive dysfunction. It is commonly employed in populations with neurological conditions such as traumatic brain injury, stroke, dementia, and Parkinson's disease. The test is most useful in clinical contexts requiring assessment of cognitive flexibility, visual attention, processing speed, and task-switching abilities. Its sensitivity to frontal lobe dysfunction makes it valuable in differentiating between subtypes of cognitive decline and monitoring disease progression. Additionally, it serves as a tool in neuropsychological evaluations to guide rehabilitation strategies and evaluate treatment outcomes. The clinician provides the examinee with a sheet containing 25 numbered circles randomly distributed on the page to perform Part A of the trail-making test. The examinee is instructed to draw lines connecting the numbers in ascending order as quickly and accurately as possible. For Part B, the sheet contains a mixture of 12 numbers and 12 letters distributed on the page. The examinee must connect the circles by alternating between numbers and letters in ascending order. For example, 1 to A, then A to 2, and so forth. The response format is oral and motor. The examinee verbally confirms each connection while drawing lines on paper. The time taken to complete each part is recorded in seconds. Errors are noted and corrected by the examinee under supervision, with penalties added to time if significant. Reference values vary by age, education, and cultural background. For adults aged 25 to 65, normative times for Part A range from 25 to 50 seconds, while Part B ranges from 40 to 90 seconds. Longer times may indicate deficits in visual attention, mental flexibility, or processing speed. A Part B to Part A time ratio greater than 3 suggests executive function impairment. Error patterns provide additional information on cognitive control. Results should be interpreted considering demographic factors and clinical context. The sensitivity of the trail-making test ranges from approximately 75% to 85% in detecting cognitive impairment, indicating its ability to correctly identify patients who have the condition. Specificity varies widely from 65% to 90%, reflecting the test's capacity to correctly exclude individuals without impairment. Sensitivity measures the proportion of true positives correctly identified by the test, while specificity measures the proportion of true negatives correctly excluded. For example, if a patient with mild cognitive impairment performs poorly on the trail-making test, high sensitivity suggests a strong likelihood that the impairment is accurately detected. Conversely, if a cognitively healthy individual performs well, high specificity indicates the test is accurately ruling out impairment, minimizing false positives. These metrics depend on the chosen cutoff scores and the population assessed. The trail-making test was developed in the late 1930s by Rayton as part of a battery of neuropsychological assessments aimed at evaluating cognitive functions related to frontal lobe efficiency. Since its inception, numerous studies have established its validity and reliability across diverse populations. Psychometric evaluations have demonstrated test-retest reliability coefficients ranging from 0.7 to 0.85, indicating consistent performance over time. Construct validity is supported by strong correlations with measures of processing speed, attention, and executive functions, typically in the range of 0.6 to 0.8. Criterion validity has been confirmed through comparisons with clinical diagnoses, where the test effectively discriminates between individuals with brain injuries and healthy controls. Moreover, normative data have been developed for various age groups and education levels, enhancing its interpretative accuracy in clinical settings. Functional neuroimaging studies conducted by researchers such as Zaxanese and colleagues have revealed activation in the prefrontal cortex during test completion, corroborating its sensitivity to frontal lobe pathology. Cross-cultural research also supports the test's applicability internationally, with adaptations maintaining psychometric robustness. Collectively, these findings affirm the trail-making test as a scientifically supported tool for assessing cognitive processing speed, mental flexibility, and executive functioning. Thank you for watching. For complete information and official PDF resources, visit clinicaltoolslibrary.com or check the link in the description below. And don't forget to like and subscribe for more clinical insights.